All right. Hey, Lindsay. This is Dr. Haney. I'm here talking with family. This is page number 1.
Okay.
So this is the first picture that we took as soon as I looked inside of the abdomen. Then I looked at the liver, ribs, diaphragm on the right side, a little bit at the central correction at the base of the falciform ligament on the right side, a heart beating, diaphragm on the left, ribs, liver on the left, stomach, spleen on the left. Then a little bit better, more close. The left is clean. I didn't see anything on the left. I know she was complaining of some stuff. I didn't see anything there.
Okay.
So this next page, this is kind of like, this is the spleen, and I'm looking a little bit more towards this side. So then I go back on the right side, and I see these, looking here, I'm actually looking at like this side. Like,
Okay.
I'm not the front of her ribs, like before they hit the spine, like midway right here. So that's clean from that side. I lift the liver and I push down, but here I found like a white spot, like right there. So I know that she had endo behind the liver. And at the end of the case, when I lifted the liver and I cut some of that stuff, I found endo like behind the liver on top of her kidney.
Okay.
Okay, good. So now I go inside of the bladder, put a stent in, put some green on both right side and left side.
What's the green for?
So that it can helps me find her ureters in the pelvis in case it's really bad.
Okay.
So then I distend her bladder, and then when I empty the bladder, her whole bladder starts to bleed. So she doesn't complain of a lot of urinary symptoms, but she has like the chronic bladder inflammation.
Okay.
So I don't know if a lot of stuff she was feeling, it was bladder or uterus, because now that she may notice the difference. Because her look at, like, this is us filling the bladder, emptying the bladder, she starts bleeding from the bladder, from the walls of the bladder. Okay? Over here. So then her bowel was stuck at normally over here, covering the tubing over on the left side. So I cut some of that scar tissue, and some of it, when I do, was endometriosis. So after that, her ovary on the right side was stuck to the pelvic side wall. That, again, like I said in the office for you and me, is like somebody staples our testicles to our legs. So then after that's elevated, then I'm looking down into the pelvis, and I see the ureter coming inside.
Is the scar tissue
3.
from the endo?
So two.
So right 3?
Yeah, 2 and page 2
Oh,
3.
I wasn't following
Yeah.
along. Okay. Okay.
2, 3.
So is the scar tissue from the
From
endo?
endometriosis, yeah.
Okay.
Yeah.
Okay.
So then this is basically her psoas muscle on the right side. This is more of her right lower pelvis, over of a nerve that's called the general femoral nerve, which gives sensation to like this area of the leg. So then that's a spot of endometriosis, and when we cut it, you see the nerve right under it.
Yeah.
And that whole thing was cut without injuring the nerve.
Okay.
Then look at the back of the uterus, the cervix, and I have this whole side wall. I'm trying to make sure that this is hopefully one of the last surgeries she'll ever get. So until we come back to take out her ovaries, which we may have to in the future, but when she's like 55.
Okay.
So then this is the sidewall before we cut it out, and this is before and this is after. The whole sidewall is resected, and then we put a rectal probe in and deviate the rectum to the contralateral side and completely resect all the peritoneum. And when we do that here, she has a hole there, and black tissue here, and more, just multiple lesions of endometriosis throughout anything. So I take a knife and I cut right to the edge of the rectum, and then everything that had endometriosis, because so the issue with some of her endo is that, imagine that this is the rectum, right? So she has like a spot here. So instead of me making weird holes, I just cut the whole thing.
Okay.
All right. So that way, like, the whole thing is refreshed, and she should not get endo back there again.
Okay.
Should not.
Right.
Okay? So before, after. So how do I know I'm deep enough? Because I'm cutting and I'm finding fat. So fat is good. Because imagine you have a drywall. After you take the drywall out, you have insulation and then studs. So fat is insulation. So the whole drywall is removed, and I have this fat right here, but she had a cyst to the right of her rectum, right? So then I have to go deeper and cut the whole cyst out. So then we put the rectal probe and deviate it to the other side, but I found that she has another hole behind her vagina. This is the cervix, this is the rectovaginal septum. So this we have to cut. And then you see when I open it up, she has more deep infiltrating endometriosis touching the back wall of the vagina on the left side, which again can be a reason for pain with deep penetration. So this is the rectum, which is now bare, and I remove everything until I get into that fat layer and get the back of her vagina completely resected. Following that, I do the same thing that we did on the right side. This is the rectum, and then the whole thing was resected, the whole wall and all the tissue to the left of the rectum. But initially I did the right side, then we did the left side. After that's done, elevate the ovary, and then from her private surgery, there's like a scar here, so the whole thing comes out. So this is the ureter, this is her left inferior hypogastric nerve, and then this is us shaving everything off the ureter to make sure that like we're never having to do any work in this location again, and everything is going to develop new tissue on top of it. It's like, imagine you have a skin and you take a knife and you basically shave the top layer of the skin, so everything is going to regenerate, but this time hopefully without any endometriosis.
Okay.
So this is the nerve that controls her bladder, and I'm pulling it, and then you can see the trajectory of the nerve here. So we had to do what's called neurolysis and kind of shave some of the nerves away from the areas that we're going to cut, because the nerves are like hair fibers, so they're very so before I start cutting stuff, I want to see where the nerve is going, and then everything that's above the nerve gets resected.
Okay.
So ovary, nerve coming from the sacral promontory on the left, ureter coming in, the whole thing is removed. Okay. After that, she had some more tissue of endometriosis at the base of the ovary that was remaining on the left side, which we are going to resect as well. So she had
You're
evidence.
going to?
Yeah.
So, okay.
No, we're going still.
Okay.
So, on this page we have the ovary. So after we cut that tissue that was over here, then we start cutting the top portion of the ovary, because she had evidence of deep and superficial endometriosis on the ovary on this side. And then she had endometriosis close to her left groin, right? So I don't know if she ever complained of pain right here on the groin, but then she has a spot of endometriosis at the base of the round ligament here, which we resect. So because we had to make a hole in her groin and we leave water inside, it's a possibility that her vulva may swell. But not because it's like inflamed, it's because water is now going to go into here and going in front of her vulva.
Temporarily or permanently?
Temporarily.
Okay.
Temporarily. I mean, this skin, she developed skin here in like 48 hours, 72 hours.
Okay.
But if I'm telling you, just in case she gets up and she sees that her labia can be as big as testicles, like big, long. So it's just pressure. She just puts pressure and she should be fine. Okay? And it's temporary. So then after that, we cut all the peritoneum in front of the uterus that had endometriosis, and then we basically kill the uterus by cutting the blood supply to the uterus on both the right side and left side, and then we take the uterus out, and then we basically suture the vaginal cuff in multiple locations in 2 layers to give it strength. Okay? And then we cut out endometriosis from the top of the ovary on the right side, and see some fibrotic tissue over the ureter on the right, which is also resected. After that, I inspect the bowel, which is this that you have over here. And the bowel had evidence of inflammation, but what I thought was on the bowel was actually that second pocket that she had behind the vagina. And it was thickened, but when I got inside and separated it, it was separate. So it made me happy that we didn't have to cut her anything in her intestines. Now, the top of her intestine has some swelling, but it doesn't look like endometriosis, so it could be swelling from all that endo surrounding it, so we'll see how she does in the future. Okay? So after that, we took out her appendix, sent it to pathology, and then we proceeded to basically cover her whole pelvis in tissue to minimize scar tissue formation. So this is the best tissue on the market to minimize scar tissue formation. Like one of these shears is like $4,000. We used 4 just to like prevent scar tissue. Okay? So after that, I turn the robot around and start now looking up here. So this is the liver. This is the liver. This is her gallbladder. This is her kidney right here. And then this is some of the tissue that we're resecting. And when we do that, we get on top of the kidney endometriosis. See all this stuff behind the liver. So the whole thing is resected and sent to pathology. So after that, I basically go over the liver and I find the reasons for her getting lung collapses. Number one is that she has a bunch of holes from the bottom of the diaphragm, from on top of the liver, that go into the chest.
I remember you saying this is the cause. Yep. Okay.
Yeah. So then when she got her period and she started bleeding, air from her vagina went in the uterus, in the fallopian tubes, and got sucked into her chest. Okay. Now that the vagina is totally closed, no air is going to come in. But she has a whole bunch of holes here.
Wow, that's a lot.
That's a lot.
Yeah.
So this should be like this, like not transparent.
Right.
So what you see on the other side is actually the lung moving. So whenever she gets a period and this gets inflamed, air gets in and it collapses.
Okay.
So the issue with this is that if they become bigger, the liver can actually push into the chest and she can have a liver herniation. So at some point in the future, we got to come back, but it's going to be a simpler surgery than this one.
Okay.
Okay? But
With you though, right?
with me and cardiothoracic.
Okay.
Okay? Congratulations, you're not crazy. We'll talk later. Bye.